40 to 50% of the population now is suffering from fatty liver, and at least 30% of all the liver failure patients that I see today in my clinic are because of fatty liver induced liver failure. And so, in order to be prepared for treating these patients, I think we all need to be updated about the advances that are happening. So this is my wonderful team at Apollo Hospital with our beloved chairman, Dr. Pratap Chandra Reddy. He is 92 years young, I would say, because he still shares the dream and vision and make sure all of us follow his path to make successful lives. So the Apollo Hospital where I work is called the Apollo Main Hospital, which is located in Chennai, and it was started in 1983 as the first private multi-specialty tertiary facility in India. The hospital started with only 150 beds and not more than 250 employees, and it has transformed the healthcare delivery in India. I'm really happy to see how it has transformed in Sri Lanka also. But to start with, in India, really Apollo has changed the entire healthcare sector with not only just hospitals, but we also have educational institutions, two medical colleges in India, one in the United Kingdom, the largest chain of hospitals in the country, and also largest retail network with laboratories, pharmacies, and we initially also started the health insurance, and then now it has been gone into private equity. So it also has the largest integrated health system, the different verticals that were shown to you in the video. And the expertise in Apollo is driven actually by academics and research. We do have academic programs and also even online education with the MedVarsity. Almost 152 countries are participating in these programs, and more than 5 lakh graduates have trained for this online university. There are almost 800 publications every year from the different Apollo institutions, and definitely research is at the forefront of our innovation. So today, I should say 2025, the hospital where I work, the main hospital, is the leading quaternary multi-specialty referral hospital with several centers of excellence. Overall now we have more than 550 beds and 35 plus specialties and more than 3,700 employees working under one roof. So Apollo Hospital has been recognized as the best corporate hospital in the country for several years continuously. And with regards to transplant, the landmark achievements have all started here. From the first successful pediatric liver transplant, the first successful adult cadaveric transplant, the first successful multi-organ combined liver kidney transplant, all of them were done successfully at Apollo hospitals. And the youngest pediatric liver transplant in India done in 2008. I'm very happy to say that he himself has graduated as a doctor, he's become a surgeon, and he's currently working in Apollo Hospitals, Bangalore. He aspires to become a transplant surgeon himself. So the other landmark achievements have been that we did the first en bloc combined heart and liver transplant. Post heart and combined transplant, the patient has been married, has 2 children, and he now when he walks into my clinic for a follow-up, nobody even believes that this guy has undergone a combined heart and liver transplant. And also the first simultaneous liver, intestine, pancreas, called the multivisceral transplant was also done at Apollo. And the Apollo transplant program till now has done more than 25,000 kidney transplants and more than 7,000 liver transplants in adults and children. And it was a very exciting day when 5 donors, families consented for organ donation. Almost 23 organs were harvested in 36 hours, of which 18 transplants were done in our hospital itself in a span of 36 hours, which was I would say, a big achievement for the families and definitely very exciting for the doctor working there. So I will start off with a few successful incidents of how transplant has changed the lives of people. This patient was diagnosed with liver failure and recurrent hospital admissions for decompensation. He was stabilized with medical management and evaluated for liver transplantation. This is the typical scenario of a patient with liver failure. He was waitlisted for a deceased donor liver transplant. I am also proud to say that Tamil Nadu has been the leader of disease donor organ transplantation in the entire country, with the organ donation rates almost 10 times higher than the rest of the country. And this patient underwent a successful liver transplantation and recovered well. And as you can see, this is exactly 2 weeks after the transplant. He started living already a completely normal life. And almost always, the success of transplant is not just for the patient, but for the entire family itself. And there are also incidents like this, the acute liver failure. This child, 2-year-old, had fever with jaundice for a week duration. In spite of extensive investigations, no specific etiology could be diagnosed. But then the child started slipping into rapid liver failure and unconsciousness. His bilirubin had risen up to 45 and of 3.5, which suited the criteria for acute liver failure, and so the family was counseled for an urgent liver transplant. The father was fit for liver donation, and after evaluation, the child underwent a successful living donor liver transplant. And the donor was discharged on day 5 and the child on day 8. I put up this picture to show the picture above is of the child before transplant, and the picture below is of the child 1 month after transplant. So he's exactly doing what he's supposed to do, play with the toys rather than fight for his life in the hospital. Not just for children, even elderly. The oldest transplant patient is 75 years in our hospital, and this lady, 69 years, was diagnosed with decompensated chronic liver disease, had recurrent ascites and encephalopathy. She was evaluated and listed for disease due to liver transplant. She was listed and waited for almost 8 months with recurrent hospital admissions and medical stabilization. Finally, got an organ allocated and underwent a successful transplant. And we used an advanced organ preservation technique, of which I will explain later. But then she had an uneventful surgery and discharged on day 1, day 7. She's recovered well, and her complaint now is that her husband is not taking frequently for shopping. So, not just for liver failure, but also transplant is a very successful treatment for tumors. In fact, a branch called transplant oncology is actually coming up. We only think of surgical oncology, but many of the cancers previously unresectable can actually be treated with successful transplantation, sometimes even combined multivisceral transplantation. So this young lady, 25-year-old, was evaluated for pain and weight loss, found to have multiple nodules in the liver, diagnosed to have a rare tumor called the hepatic epithelial hemangioendothelioma, occupying the entire liver, both lobes, which is unresectable. So at this point, the family was counseled for organ transplantation. The uncle was fit for liver donation, and as you can see, after transplant, she successfully recovered. She was married at that time, but then 2 years later, she had a child and now leading a completely normal life. So, traditional contraindications for transplant, like portal vein thrombosis. As we all know, liver has a dual blood supply with the portal vein and hepatic artery. Both these blood supply need to be reconstructed in a graft for it to be successful. So, when the portal vein is completely thrombosed, blocked, you cannot give the blood supply to the liver, and so it was considered a contraindication for liver transplantation. Not anymore. Like in this patient, as you can see, the formation of the portal vein is completely blocked at the level of the complex of the splenic vein and the mesenteric vein. After that, it is replaced by a leash of collaterals. But then, with experience now, we are able to successfully do transplant even in these patients. Like in this patient, the cirrhotic liver was removed, and the entire thrombus was actually removed, and the successful reperfusion was done. And as you can see, liver is also a very dynamic organ. The moment the blood supply is recirculation is established, the liver starts producing bile, and that's the sign of a successful transplant. So this man underwent a successful transplant. Before and after recovery, you can see how happy and how healthy he has become. And the other recent advance that is happening in liver surgery is of the introduction of minimally invasive techniques, especially robotic surgery, because it has a shorter learning curve, the instruments are fully articulating, also has intuitive computer enhanced motion control, is very ergonomic because the surgeon is sitting in a console and operating rather than standing for hours, bending across the patient. It has very stable visualization and also has integrated imaging. For example, the ICG can be integrated, superimposed on the robotic image, or even the technology has come to a stage where the CT scan images can be superimposed on the robotic image, and so the identification of tumors, the identification of vascular structures, biliary structures can be very accurate, and the surgery can be very precise. And as you can see, the biggest advantage is that it avoids this large unsightly scar. It not just has a big cosmetic advantage, but then also has a lot of functional advantages because this large incision in the upper abdominal. It interferes with the breathing in the immediate postoperative recovery period. In robotic surgery, it is taken by a lower abdominal incision, and also this is a muscle splitting incision. The linea alba is just split to retrieve the specimen, whereas in the robotic, the open surgery, it is a muscle cutting incision. So the chances of pain, complications like incisional hernia are higher, and even adhesion and intestinal obstruction are more with this kind of a scar and very less with minimal invasive surgery. So as you can see, the surgeon sits in the same room while the robotic arms are operating on the patient. So this was one instance where we operated on a 2-year-old child, 14 kg weight, had biliary atresia, as you all know, which was treated at a later stage, could not be salvaged, and so a transplant was advised for this child. And his father came forward for donation. His left lateral lobe was decided to be transplanted onto the kid. And this is the typical port placement. And as you can see, the site mark for the lower abdominal incision and the retrieval of the graft. And the short video clip. Oh, sorry. Can you just tap over so she can? As you can see, the robotic instruments have a advanced rotation and articulation, and so the ability to reach deeper structures is very good. The surgery starts with the division of the ligamentous attachments of the liver. The falciform ligament is divided, and then for the left lateral lobe, the left triangular ligament is also mobilized so that the left lobe can be free. And the energy source with the robotic instruments are very good, very controlled, and so as you can see, the surgery pretty much goes on in a completely bloodless fashion. Sometimes in open surgery where the blood loss used to be 400, 500 ml, with the robotic surgery it is less than 100 ml. And also the other factor being pneumoperitoneum. The robotic surgery is conducted by air insufflation into the belly, so that reduces the venous bleeding. And the next step is to do the portal dissection with the hepatic artery and the portal vein being identified. And this is where the gallbladder was dissected to keep the traction on the bile ducts. And then subsequently, as you can see, the porta is dissected to identify the gallbladder coming out. Yeah. And the magnification that we get with the robot is 10 times magnification. So even very small blood vessels are appreciated very well so that they are preserved and injury is completely avoided. And you can see the scissors is integrated with the energy source. The dissection is completely bloodless. We are dissecting the blood vessels here, the portal vein and the hepatic artery. It is a 2 millimeter size blood vessel, and then you can see how big it is, the hepatic artery. Even while operating with open surgery, we use the magnification loops, which are only 2.5 or 4 times magnification, but the robot we get almost 10 times magnification. And after the artery is dissected, we go on to the left portal vein. These are the inflow blood vessels. Normally for a hepatectomy, the moment they are dissected, we would clip and divide them. But then in a donor surgery, we preserve them. This is the integrated ICG imaging, where the ICG dye is injected before surgery, and by identifying the left hepatic artery portal vein, if you clamp them, then completely the left side of the liver does not take up the ICG. So the transaction line of the liver can be identified. You can see by after identification of the left lateral lobe by the ICG technique, we are now marking the transaction line of the liver. This is a, we call it the rubber band technique. I learned it from a Korean surgeon. Keep the liver retracted, and it also uses the laparoscopic fusor, which is a advanced instrument to transect the liver. Gone are the days when liver transection used to incur a lot of bleeding. As you can see, the transection can be completely bloodless, and all these blood vessels that you see here are very small, but then with a good magnification you identify and avoid injury to all of them. So we have more and more robotic gadgets coming now. Initially, robot did not had only the scissors and dissectors, but now we have a robotic user also. Here we are using the laparoscopic user, we have the robotic user, we have the robotic staplers, and so surgery by robotic technique is definitely becoming much more safer and much more comfortable. So the entire transaction is completed in this manner, and then the bile duct division. This is again another safety measure where the contrast gets concentrated in the bile ducts, and the bile duct can be accurately identified and divided. This is a very important step because dividing the bile duct closer to the confluence sometimes injure the bile duct for the opposite side. So by using the ICG technique, we identify the location of the confluence, stay away from it, and avoid injury. And after the bile duct is divided, it is time to now prepare for the graft to be retrieved outside. So we identify and clip and divide the inflow blood vessels, namely the hepatic artery and portal vein. And this is the dissection of the outflow hepatic veins. They are actually stapled, and then finally the graft can be safely removed by an organ bag. Just you can just forward isolation of vascular presentation. Yeah. So this is the child, as you can see, and the donor, as you can see, at day 8, when the child was discharged, he's already recovered well, and which is the big advantage of minimally invasive liver surgery. So, coming to another major advancement is about the preservation technique used in the liver transplantation. Conventionally, the organ ischemic times are very limited. The heart stays in the eyes for not more than 4 hours, the kidney for not more than 24 hours, the liver traditionally less than 10 hours. But then today, like the Terminator would say, the machines will rise. Yes, it is already rising in transplantation also. Oh, this machine is not working. So this is the machine that I was speaking. This is a US FDA approved transplanting machine for preservation of organs. They have separate machines for each organ. There you can see the liver, heart being preserved in the OCS heart, organ care system heart that we call, where the organ is actually outside the body but simulated to be within the body. Blood is circulated at normal human body temperature into the organ, and the effluent from the organ can actually be tested for biochemical parameters to assess the function of the organ. So we also do have a separate machine for the liver. This is the normothermic machine for the liver. The liver is kept in this box, and as you can see, like a patient monitor, we have a monitor to assess all the parameters for the liver also.